Hey guys, hope everything's going well. Sorry it's been a while since we've had a video update, but I want to take a few minutes since this week was all about emergency services or emergency department integration and trauma program integration, and just share a few of my thoughts as a former hospital administrator who ran emergency departments and trauma programs with regards, as well as hospital-based EMS and integrated with community-based EMS services, 911, and so forth. Let me first say, I think when I started in EMS over 20 years ago, we had really had a pretty adversarial relationship with our emergency departments. I would say that wasn't unique to us, and it was a trend that we'd seen pretty consistently across the board. One of the things that I've appreciated over the last 20 years of change is that we have moved from an environment where there's a tenuous relationship to an environment where we really have to function as true partners in the continuum of care. I'll give you a couple examples of those experiences as I've seen them. I know the posts have been great with regards to your perspectives on things that you've seen and the way we should integrate. But I think it's really important to note that we can no longer serve as a public service entity, but more as a healthcare provider when we deal with the EMS side of the house, purely because that's what our patients expect. The bar has certainly been raised from where it was 20 years ago. One of the things that's really, I think, important as future EMS leaders to understand in the civilian world specifically is that essentially all accreditations emergency departments go through have an arm that is evaluated specific to EMS. We spent a fair amount of time talking about trauma, and I will say this, in the trauma we call Resources of Optimal Care manual, which is really what all trauma centers use to accredit themselves through the American College of Surgeons. There's an entire chapter dedicated to EMS and EMS integration. And when I say there's a chapter, it means there's a complete standard. And so a part of that is partnership with EMS, education of EMS, EMS integration with the continuum of care for trauma patients. There's an expectation that they'll be calling traumas from the scene, or at least making those judgment calls to initiate the process with the Verified Trauma Center. The Society of Chest Pain Centers has an equally large, actually probably larger section for EMS integration. And the Society of Chest Pain Centers, what they really look at, frankly, is another full element on EMS and EMS activation of STEMIs, EMS integration with community education, EMS integration with AED programs. Really, it's a pretty comprehensive program. And stroke centers from the Joint Commission are no different. So I think it's really important as you progress in your careers and certainly through this education that you recognize that we are no longer able to be bystanders. I have requested copies of those elements from from the American College of Surgeons and from the Society of Chest Pain Centers. As of yet, I have not received them, but when I do get them, I will post them for your review. I think it's really important you understand those elements. I think furthermore, we're seeing a huge transition from us being just simply field providers to now healthcare and emergency medicine professionals versus simply being the field medic, the technician, the ambulance driver. We now have a higher level of expectation of professionalism, and certainly you're proving your commitment to that by pursuing a degree in emergency health services. We've talked a fair amount in the last couple weeks about being the leaders in promoting clinical quality. I think it's really critical to grab hold of that concept from the standpoint of being the leader and the initiator for healthcare advancement in the field. Unfortunately, we have as of this week begun talking more significantly about EMS medical direction, EMS board, subspecialty, and hopefully that will do as we hope, and that would be to foster a new generation of EMS medical director who really is vested in what we do in the field and will lead that clinical initiative. However, as administrators in the field, I think it's our responsibility to ensure, one, we provide good quality care, and two, we continue to do it as efficiently and cost effectively as possible. The third thing I wanted to touch on relatively briefly was, as you know, I was in Las Vegas presenting at EMS World Expo this week, and while I was there, had a great opportunity to meet with some of our top EMS physicians and discuss the mobile integrated healthcare model that is being launched now throughout the country. And essentially that's built on the tenet of what they call the triple aim. And the triple aim is lowered costs, improved patient experience, and improved patient outcomes. These are being driven by the hospital side, the healthcare initiatives, and frankly, without those three elements, what we're finding is that reimbursement, at least when I was running the emergency department, as well as, and I don't know that you know, but I ran the hospitalist program, which was the inpatient hospital services physicians. We found our reimbursement, if we in fact held on to patients too long, didn't expedite care, if they were readmitted, not being reimbursed. And so the drive, the main driver behind this mobile healthcare integration is really to identify those patients who may require readmission, because frankly, on the hospital side of things, if Dr. A sees a patient for congestive heart failure, and that patient is readmitted within the next 30 days for anything, if it could be a head bleed, Dr. A is responsible for that person's care and will not receive any further reimbursement. It sounds crazy, it sounds like it's unbelievable, but I can assure you that it in fact is happening. And so part of the drive behind this mobile integrated healthcare would be to send paramedics then out to that congestive heart failure patient's home to ensure that they're compliant with their medications, that they are not exacerbating their heart failure, and if they are, that those paramedics that arrive on the scene for a follow-up visit would adjust medications in accordance with protocols and medical direction. They would evaluate the patient and determine whether they need to come back in or not. Those are some of the examples that they're using, but frankly, I think this is something that's here to stay. The ever-changing climate in healthcare reimbursement has certainly prompted this. It's something that's been discussed for many years. However, we now are actually seeing units currently at work in Texas. AMR, the largest private ambulance provider in the country, their medical director, a guy named Ed Rock, I've referenced him a few times, who's really driving this as well. We're seeing it in Reno, Nevada. So it's something that's here. I believe it's here to stay, and something that we need to be prepared for. So those are a few, I think, hot button issues. I would say. I don't want to spend a lot of time with this real lengthy video, but I do really want to identify those as some things that are unique or different from what you may have experienced in the recent past. That's pretty much it. I think I may revisit this, at least in the form of an additional announcement or email out to you all, but I appreciate you sticking with me during this last week at EMS Expo, and look forward to a great rest of the semester and a lot more engagement. You guys have been awesome, and I really appreciate your engagement, and it's making the course really fun for me and interesting as well. So have a great night. Take care.